35% of the time, 1 in 3 women walk into the hospital to have a baby, and 1 out of those 3 women walk out with major abdominal surgery and a baby to take care of with zero resources or support around her. We start manipulating birth. Birth was not meant to be manipulated. The thing that we don't talk about most is that you have to show up to your birth space prepared to face your biggest fears.
Welcome back to the Female Blueprint Podcast. I am so excited to welcome Tracy, a board-certified nurse midwife and passionate advocate for women's health. Tracy started her career in labor and delivery and spent 13 years caring for premature infants in the NICU before returning to women's health after earning her master's in nursing. She's been instrumental in bringing midwifery services to Banner, Australia here in Phoenix, Arizona, and is committed to supporting women at every stage of life: preconception, pregnancy, postpartum, and beyond. Tracy believes in a holistic approach to wellness, combining nutrition, exercise, spirituality, and individualized care. Outside of work, she's married with 2 daughters, loves CrossFit, yoga, hiking, and traveling, and lives by her motto, lead from the front. Tracy, welcome to the podcast.
Hi, thank you for having me.
I am so excited you're here. I just love and adore you. 1, as a person, 2, as my midwife.
I'm so excited that I get to take care of you. Yes.
You're the best. I can't wait for listeners to hear your story, more about what you do, and insights on birth and postpartum and everything. So let's dive right in. Tell us how we got here today.
Yeah, so my story is I think like a lot of young girls who are just, trying to find their way. I was 14, I think, when my sister had a teen pregnancy, and she was very, she played soccer. She's very, I don't want to say masculine, but she's just not like a girly type. And I was one of 4 girls in my family. And the joke in my family is that I've had a baby on my hip since I was big enough to walk. Like, I loved babies, always like into pregnant bellies, and nobody really in healthcare in my family. But when I watched my sister go through the birthing process, she was 19 years old, and my nephew had some health issues, so she was kind of considered high risk, and she ended up getting preeclampsia and delivering in Cincinnati downtown at a tertiary care center. And I just remember like her coming home, and she was in college and she wasn't married, and she was like eating teenage food, and I'm like, what are you doing? You have to eat this. I just remember like mothering her and taking care of her, and she was so sweet to let me be a part of her pregnancy journey. So I got to be in the delivery room when my nephew was born, and I was only 14, and it just really had a profound impact on me.
Wow.
I was like, well, I am going to do that for a living.
Not many things you get to do at age 14, and that is sure as heck not one of them.
Yeah. And it just really like solidified that I wanted to be in a space where, I could make a difference and be in something that I was passionate about. So I knew from that moment on that I was going to do nursing for sure. And there were no midwives really, or there were midwives. I wasn't aware of midwives when I started out my journey. And I told my mom, I'm going in between nursing and medicine. And I was the first person to go to college in my family, just even to go to college, let alone graduate. And my mom was a stay-at-home mom of 4 girls, and very traditional upbringing. And she was just like, Tracy, like, I don't know that you're smart enough to go to medical school. I mean, you're a girl, nobody in our family, very kind of discouraging, not in a bad way, but she had a very much like fixed mindset because that's how she was raised. And I was very much like, if you tell me I can't do it, I'm gonna. So I started school pre-med, and then quickly, before I even got to school, like I applied for pre-med. And then right before I started school, she really was like you always wanted a big family. I really think you need to reconsider this. So long story short, I went nursing. And I loved nursing. I was really, I got to train at University of Cincinnati, which is just hands down one of my favorite places. Like I tell people all the time when they're like, "Oh, you practice different than other people," or like University of Cincinnati was such a holistic place. They were way above their like
Wow.
way yeah. Cincinnati Children's and UC have been around for over 200 years, and they're very well funded in academia. So I was really blessed. I didn't know it at the time, but to go to that school, I definitely look back now 25 years later and see what I was exposed to and what nursing students get now. And it just, my training was, I'm so grateful. So I went into nursing school. I graduated and came out doing labor and delivery. I was labor and delivery at like a level one hospital that was like by Miami, Oxford, out in like the hills of Ohio. And I had two of the best preceptors that you could have ever asked for, Carol Zindel and Marilee, if they're listening. I still talk to them. They paved such a beautiful path. They took me on as this little new grad and they taught me everything they knew. And back then, when you were labor and delivery, like you did everything. You scrubbed, you were labor, delivery, postpartum recovery. Um, and you really at these outlying hospitals had to be like really on top of your game because you were your first and last line of defense for these moms. So I had trained at Cincinnati Children's and did my externship in the neonatal ICU. So I did something called stable, which allowed me to be the person to take care of some of these babies because we didn't have a NICU. So anytime these babies would be born and would have complications, I would end up transitioning them. And my husband was a neonatologist, and we would transport to him down at Cincinnati Children's. After about a year of doing labor and delivery, a job opportunity opened up for me to train at Cincinnati Children's, and my heart was really torn because I loved labor and delivery, but I also loved NICU. They had a day position that paid a lot more, and I got to work with my husband. So I was like,
Mm.
I'm going to take this and run with it. So I went from labor and delivery, a little over a year of that, and then I got into NICU. And I stayed in neonatal ICU for about 13 years. I was at Cincinnati Children's, and then when we moved here, I was at Phoenix Children's. And then when I had my own kids, I moved out to Banner Estrella, which was more of like a level two nursery. Um, and I really loved it. And I got to take care of moms and babies, and I got to take babies off life support and do ECMO and really just like learn a lot about women and infant services in that realm. But
Mhm.
in 2015, I had this really big sense. And in 2015, I started CrossFit probably 2010,
Mhm.
and it really changed my life from a standpoint of like just really questioning mainstream preventative health care and how to prevent disease. It just, now it's kind of commonplace that functional fitness and eating real foods and being in community with other people, like we know it's a no brainer. But
Right.
in 2010, I feel like it was a little bit more new. um,
Yeah.
so I think that that definitely had a profound impact on me wanting to get out of the acute space as an RN. And I just kept looking around in the NICU and I thought, like, so many of these babies could have avoided being here in the first place. If I could just get good preventative health care for these moms and good education, I think we could change some of these statistics. So that kind of opened up my eyes to women's health and how to become a provider. And when looking into it, I was reading about the midwifery program and I was like, man, I don't know that I could ever leave birth because it's just so like even when I did NICU, when I was out here at Estrella, all I did was attend births. Like I was what they called the baby catcher. So I would
Mhm.
go on all the deliveries. I would help transition their babies, keep them with their moms. And then any babies who were sick, I would help resuscitate and then bring them back to the NICU, and get them admitted in there. So I really had been in the birth space all of my career in some capacity, and I didn't want to leave that. So lo and behold, I looked into the programs. University of Cincinnati, of course, had a program, and there was nothing here. So I went back, and I was actually trained by my professors who taught me 25 years ago now, as a baby RN, um, which was really cool experience.
So
Very, yeah, it was awesome. So um, I that was what did it for me. I was just like, I feel like anyone who's in midwifery, it's like you get this calling. I don't know how else to describe it. Like you just know. And it's like this is bad for my health. It's horrible work-life balance, but there's just this deep calling and meaning. I always tell people, like, yeah, I'm trained in healthcare and I have a background in ICU and I get to do all these great things and I utilize those things often. But like my biggest part of my job is just holding space for women and being inside their birth space and reminding them of their power. I try to say, sit on my hands as long as I can. And the goal is to never have to use them. Um, but like kind of a protector of space. So that's one of my biggest passions. But also, I do, as you know, as a patient of mine, I do a lot of work with people with autoimmune disease, endometriosis, PCOS, metabolic syndrome, people with infertility. I really take a preventative health approach to keeping people as healthy as possible because what I correlate with fertility goes across the lifespan and health span to keep people well. So I always tell people I'm trying to keep you as fertile for as long as I can. And that
absolutely.
really just decreases all the other, comorbidities or epidemics that we're facing here in the United States that are really caused by sedentary lifestyle, a
Mhm.
lack of social support and mental health services, and ultra processed foods. I mean, they're the demise of our civilization.
Literally. Yeah.
Yeah.
Oh my
So that's
gosh.
the long story. That's
Your
the
story. Yeah. No, it's so good. I had no idea the extent of like, I'm like, how did she get here? And I'm just like mesmerized by that. That's amazing.
it's
First of all, I didn't know anything about University of Cincinnati. That's awesome. So you're not listening. That's where you're supposed to go get trained, apparently.
yeah, it's I'm a huge fan when people Frontier kind of runs the show for midwifery.
Yeah.
And I just tell people all the time, like, well, you should check out UC. In my opinion, it just has such a strong background in health sciences. And in my opinion, midwifery is really preventative healthcare. That's
Yes.
what it is. If you want to keep people
I love
well,
it.
you got to teach them how to take care of themselves. And
Absolutely.
that's what they taught me. I've learned a lot through them. So
And
they,
you're doing an amazing job now at keeping people well preconception, during their pregnancy, and obviously probably even during their postpartum journey as well, which is not uncommon. And obviously we'll probably get into this. And I know that you work now for with an OBGYN, and I'm sure you have the same alignment on practice and what's well for your patients. But there's so much out there, and obviously you know this in the birth space, like so many women are left with nothing. Like nothing at all.
yeah, I mean, we have a huge, I mean, number one, obstetrics is less and less people are training in it. It's the highest medical legal liability there is. It has one of the highest burnout rates and work life balance. I mean, really, if you're an educated person and you're going into the birth space, you're a glutton for punishment because the system is very broken. More hospitals are shutting down their maternity services because they're not making enough money or OBs are too expensive to hire and keep in the hospital. I really think that like women's health services in general. Now, I feel like in the last year, things are really like we have got I don't, what's the word when you're moving energy forward? There's definitely some wonderful things that are coming to fruition. And I think that TikTok and social media, as much um, negative connotation or as much negative feedback as people say about it, it's also been a space in which women have found community. It has
Mm-hmm.
been a space in which women are seeing truths being told and stories being shared about birth trauma. Um, so I always hate to get on these types of subjects and be like a Debbie Downer or be negative, because there's really a lot of like really heavy patriarchy and just maybe with the best of intentions, women are not getting the care and the
Yes.
support and the empowerment, and they're not allowed the autonomy that they deserve. And that's a reality. But I've been now in this space for 25 years and I've seen a lot of things come full circle. And I would say in the last 2 years, I feel more hopeful and more optimistic about the future of women's health services in the United States than I ever have. And I honestly think that COVID was a big synergist for that. I think that through all of the gray and murky areas and mistakes that were made, one thing that people learned across the board was that nobody's going to care more about your health than you will. And if
Yep.
you're sitting back and relying on our healthcare system or our CDC, the WHO, the HIS, and these organizations to care more, or know you personally better than you know yourself, you're going to be disappointed every time. And I think that it called women to be radically responsible and accountable for their health. And they started looking at, hey, who's dying from COVID? And who's
Mm-hmm.
having the worst outcomes? And these were people who, it preyed on metabolic disease, it preyed on age and, um, decreased immune systems. That's the people that it took out. And I think that it opened the eyes of women. And what's really great about women having their eyes opened about health is they are the staple of communities and households. So when a mom decides that she's going to cook healthy for her children because she's doing it for herself, first things first, um, it spreads. It spreads to her
Yeah.
husband. It spreads to her neighbor. It spreads to the community at large. And if you teach a woman how to care for herself, you're teaching the whole world to do it.
Oh, absolutely.
And having access to pregnant women is probably one of the most powerful things that I've ever been given, because there is no time a mom is more motivated to do the right thing than when she's pregnant. You want to talk
Mm-hmm.
about behavior change? You will get the most change out of anyone in two situations. One, when they're pregnant, mom's guilt starts the second that positive pregnancy test happens, or when a mom is trying to get pregnant and can't. You'll get the most compliance. They will research, they will eat, they will meal prep, they will move their body, and they will do whatever they can for their families, because that's how women work. They're very selfless. So um,
Absolutely.
I'm so optimistic. I struggle with the traditional medical model, and the way that we do birth inside of hospital systems. I still, as much change as I see, we need to just keep moving forward. We can't stop on that forefront, but we've got good momentum.
Yeah. And we're making a wave.
We're
We're
making a
making a wave.
wave. I mean, I'm not going out silently. You know that.
No.
I'm going to
Okay.
put the
I love this.
the biggest
So
dent I can before you see me retire into just women's health. I still got some birth left in me, but at
you have a
45, I'm not going to lie. I'm hoping at 50, I am just training and mentoring new midwives and I'm sleeping in my bed at night.
you deserve it. After 25 years of all that you've been through, you deserve that.
Thank
And I want that for you. Okay, so I have some questions about midwifery. Like, and women who are listening to this podcast, they might not know that that's an option for them, or it might not actually be an affordable option for them, right? So, let's get started by talking about birth. first and foremost. So many women prepare for nurseries, they prepare the clothes, they prepare the registry, they prepare for the baby, but they don't know what to expect in the labor room with their providers or even with their own bodies and what's going to happen, right?
For sure.
So what's something you see in labor rooms all the time that most women are not prepared for?
Yeah. So even in my patients, like where I start from day one, like we got to eat whole food, you got to cut I do so much education inside of my prenatal teaching. And then I pretty much make them come to my prepared childbirth class because I find that my patients who attend childbirth class versus my child patients
A
who
little bit
don't, like their outcomes are significantly different.
Wow.
And even my patients who come to my class, I really have switched my prepared childbirth class up to really talk about like the mental, well, how about we say the brain and pelvis connection? Um,
Mm-hmm.
I have a lot of theories from watching birth for as long as I have about how do we get our babies out. And like you said, so many people talk about like, you can go to Lamaze and you can do hypnobirthing and you can learn to breathe, and you can eat healthy and you can go to Pilates every single day. But if you come into your birth space and you have trauma, which 1 in 3 women have some type of domestic violence, sexual trauma, adverse, outcome from childhood, you bring that into your birth space. I don't know exactly why that is. I definitely have theories to it, but the thing that we don't talk about most is that you have to show up to your birth space prepared to face your biggest fears. And you don't just push your babies into this world. I think we release our babies into this world. And there's a lot of misconception about, we teach women how to push and how to open glottis push and how to relax their pelvis. But there's a psyche that's involved there, and fear and trauma is stored inside of our pelvic floor as well too. And really, honestly, I mean, this as a pelvic floor PT, we do not, like, the general population doesn't understand that our lives and the way that we live them and the pace at which we keep is not aligned with giving birth. Meaning, your central nervous system needs time to come down every day. And our alarms are going off at 4 o'clock in the morning. We are hitting the pavement running. We are doing HIIT training and lifting weights. And if we're lucky, we then go to our jobs, we come home, we cook dinner for our families, and we've got 30 minutes of winding down at the end of the night.
And that time is always spent like scrolling,
You doom scrolling. Like,
checking out.
I want to just check out from anything. And it's
Yeah.
really created an environment or space where women are entering, like they're doing all of these things. We've almost emphasized it so much, like now we're putting more work for them to do to get prepared for birth. I'm like, I kind of approach things differently. In general, don't necessarily do any type of cervical exams. Um, for my patients, like if they're up to date on their pap, like I'm not putting my fingers in anyone's vagina unless I have to.
Mm-hmm.
But what I've learned from doing that is you can tell a lot about a woman's pelvic floor by doing internal assessments. We're just like touching the inside of their legs, or even just like watching my patients sometimes.
Yeah,
I'll ask them now, like, are you a type A or a type B? And they're like,
totally.
what is that? And I'm like, it's very important information to know.
I need to know.
You need to know these things. And I definitely think that I really used to just focus on like sexual trauma. I really needed to know that prior to going to the birth space, because many women who have had sexual trauma or have had abortions or even like very uncomfortable miscarriage or mid trimester losses, they don't understand that when they feel that pain that comes back that they experienced, it's very triggering and it shuts down the central nervous system, which clenches down the pelvic floor.
Mm-hmm.
And I don't think they're prepared for that. Like, I don't think if you've never been in birth before, like, it's like an insider's club. Once you've been in labor, when you're around someone who hasn't, and they're like, yeah, I mean, I know it's going to be hard. And then you're sitting there with someone who's given birth, and you're like, when that first contraction hits, you're like, or I'll have patients say to me, like, I think I'm in labor, but I'm not for sure. And I'm like, if you're not for
You'll
sure, you're not in labor.
you'll know.
And you can't really explain it because it really truly is just such an intense thing. It's like your body takes over you. It's very primal, and if you're the type of person who wants to be in control over your body, it's going to be very uncomfortable for you because it's going to do what it wants, and you have to learn to ride that wave and breathe through it. So that's why, classes like Lamaze and hypnobirthing and doing guided meditations are so great, because if you teach people that 5x5 box breathing, and you can kind of teach them to connect with their pelvic floor. I love yoga for a great example in
Mhm.
pregnancy because it takes you to hard spaces or positions, and it asks you to stay there and breathe through it. So it teaches you to connect your mind to your body. Some of my CrossFitters are my worst patients ever. I always tell them this. I'm like, your pelvic floor is so strong. I don't need it strong. I need it soft.
To relax. Let
I need it to come down.
her go.
So I think really like getting the time with my patients to really, honestly, the longer I'm in this, like talk to them about like what a spiritual event birth is and how you really need to spend time with, I'll just be completely honest, like spiritually with God, and knowing that when it's time that you're going to have to completely rely on him because it is very overwhelming. And I think it's one of God's lessons to us as women. I think it's a lesson to us through all of life, right? God's going to keep piling stuff on you. The stronger you are, the more he'll pile things onto you. But he doesn't ask you to be he's strong. He asks you to rely on him. And I think birth is very similar to that. It's kind of like coming to him when you're in transition and you're in an outer body experience and you think, I am at my maximum threshold for pain here. There is a moment I watch women surrender into that space or fight it. And people,
What does that look like?
it looks a lot like death.
You're
It's
like, you look like you're dying.
it's like dying to yourself. I think it's
Yeah.
like dying to the psyche and saying like, I can't control this anymore. I have to completely surrender. I don't like to make things all about God because I know that we have a lot of listeners who aren't Christian. Whether you call it the universe or just dying to your own ego, whatever, I just speak of it God because that's just
Yeah.
my belief system. But you really kind of die to yourself. And I don't mean it like it's so bad you feel like you're dying. It's so intense that you feel like you don't know what to do and you need to rely on something other than your own vices. So
Yes.
I think that knowing that you're going to go into that space, and in my prepared childbirth class, I talk to people about transition, which is the last couple centimeters, 8 to 10, where your contractions get stronger, longer, more intense. And I was taught by a granny midwife a long time ago that women leave their body at this stage during transition and they go to the stars to get their babies. And I
So,
remember listening to her and being like, dude, she's crazy. This woman is like, seriously, like,
yeah.
I laughed at her. I was, in medicine for a long time and I know
Right.
I've trained. And after a long time of watching, because you learn a lot more from watching women move in labor than you do actually doing stuff, I'm like, there she goes. She's out. She just checked
Go
out.
to the
And
stars.
I think if you really let people know that that's what's going to happen and let the dads and the partners know, like, you're going to see your partner in the most vulnerable position that you will ever see them in life. And you're a man, you're a fixer. You're going to want to fix this. Nobody can bring this baby earthside but the mom. And I think the faster that these dads realize that, and these midwives and these nurses, like everything you are and everything you have comes to a head at that moment. And we all want to save people because we're fixers, but you can't save that. All you can do is get in a woman's face. I do this all the time. I grab them by the face and I tell them, "You're doing this." Because they're like, "Do this." They go from like struggling to no, or they'll grab me by the shirt. "No, I can't do this anymore." And that's how I know their baby's about to come, because it's like they're wrestling. Maybe they're wrestling with their ego. Maybe they're wrestling with their singular self as a woman, and they're trying to cross that bridge into motherhood. They're saying goodbye to their old self and saying hello to their new self. But there's definitely an internal struggle that goes on. And when you're in the hospital and you're watching a woman wrestle with so many things, like in head and body and spirit, you can really mess with it because you want to fix things when really you just need to put your hands on her and remind her that everything she has is inside of her. So I always tell my dads that. I'm like, this is when you kiss your wife on the lips and you tell them that she's the strongest person you've ever met. You breathe every ounce of life, every compliment, every single possible thing you can muster into her with 100% assurance. That is how you support your wife. That is how you support a woman in her birth space. She needs to know that she has everything she needs to get through to the other side. And that's when you see them surrender. That's when you
This is
see that,
so beautiful.
yeah, the body then is like, okay. And I always say die, because you see them fighting, fighting, fighting. And then the next thing you know, they just get quiet after the shaking, after the "I don't want to do this," after
Yeah.
sometimes puking, peeing, pooping, like the body ejecting everything.
Yeah.
Then there's just this silence that overcomes the room. And this very like peaceful place, mom starts to kind of like fall asleep in between these contractions. And then within about 20 to 30 minutes, she's ready to roll. Like she sits up and she's like, "I have to push." Or she says, "I have to poop," is what she usually says. Because that baby, she's finally relaxed enough. She's given
Mm.
up the fight. She's like, "Do with me what you will."
Yes.
And
This is so beautiful. Oh my gosh. It makes me excited for that time period of my life.
yeah,
But there's probably listening to this thinking, okay, so this is maybe like a natural birth. Like what does it look like? And you're obviously a midwife, so we're like kind of more pro natural more than anything. So what does it look like for somebody who's epidural?
yeah.
That's a whole different route, right?
Yeah,
So
it is. It is a different route. And I always tell people, like, I'm pro whatever you are. I mean,
mm,
I wildly love natural childbirth because I think that it changes the entire trajectory of how you parent and how you mother and how you see yourself. So I'm always advocating for natural childbirth. I'm always pushing my patients a little bit, but for
yeah.
sure. I mean, I had epidurals with both of my babies, and I think
Okay.
personally that that's what pushed me into wanting to empower women, because it felt to me disempowering. I'm not
Mm,
saying like I felt like a failure, but I wasn't prepared. I was prepared by traditional OBs who broke my water at 37 weeks and encouraged me to get an epidural. And, you know, I just remember looking back on those experiences, and I think that it really decreased my confidence in myself to be able to do things and know my body and know my baby. So I love to encourage my patients that way. But for my epiduralized patients, I would say I'm probably like 70 to 80% unmedicated now. I wasn't for a long time. I had way higher rates of epidural. Um, but for my 30%, it's usually almost always my first time moms, because labor is really long. And your first labor is usually your hardest labor. So we'll utilize epidurals as a way for them to rest or for us to turn off that pelvic floor. So when you have that mom who's in that space, right, and she's active and she's breathing through her contractions and she's fighting, you see her, she's coming up and trying to get away from the baby versus opening and releasing. I'll even say sometimes if it wasn't their plan, like, hey, we've been here for a really long time and you're losing your stamina. And I'm really worried if you're not able to relax your pelvic floor. Like, we've been in the shower, we've been in a warm bath to try to relax, we've been doing massage, rebozo, nitrous. Maybe I've given some oral medications or, IV narcotics to try to just really help her cope with the pain. And she's not doing that. We can utilize those epidurals to help turn the pelvic floor off. This will
Mhm.
sometimes allow a woman to deliver vaginally who maybe would not be able to deliver vaginally had we not gotten her an epidural and really relax that pelvic floor. So I'm not anti anything by any means. Like, we have so many tools in our toolbox. um, I just wish that more people understood their power and trusted in their body more. Western society really tells women, like, why? Why would you want that? Nobody gets a medal, or, do you take a Tylenol when you have a headache, or, just
Yeah.
this, this mindset that really negates the woman's, in my opinion, like, true matriarchy. Like, I love to watch women step into their power. I even have people who will tell me, like, um, well, I think I'm just going to get an epidural because I don't know that I could do it. Like, and I see them, they want to have an unmedicated birth, but they're already feeling insecure about owning that and what might happen if they need an epidural. So I do a lot of counseling with my patients. Like, it's not good or bad. These are all tools that we have, but I try to get them to be brave and vocalize, like, hey, if you want to, let's do this. And then I spend a lot of time with my patients. Like, if they really want to have an unmedicated birth, I highly recommend getting a doula. So you have one-on-one support that is constantly in your ear, moving your body and teaching you the different things and ways that you can move your body to speed up birth. Because that's why people get epidurals. They wear out.
Mm.
You wear out
Wow.
because you're tired.
Yeah. Okay. Because I've obviously never had birth or given birth yet, so I hear it all the time. I got the epidural. Oh, I'm getting the epidural for sure. Like, I ain't doing that. There's so many stories around why they're doing what they're doing. But I love hearing this perspective of, like, oh wait, it's a tool in the toolbox that maybe you really do want natural, but you just can't get there. So that's really good. And that's really good for listeners to hear, because it's like, why don't you just try your hardest,
Well,
and then you have the tool if you need it.
and another thing that I think is really important for people to know is, even if you're someone who's like, Tracy, I have zero desire. Like, I know you have desire, but it's not my bag. I really just genuinely don't want to do that.
Yeah.
Or people who will say to me, like, I'm really scared of the pain that I'm going to have in childbirth, and I really want to know that there's something there that I can take. I always tell my patients, and this is something that I feel like is not disseminated across the board, whether it's midwives or OBs, there is no such thing as pain-free birth. There's no such thing. It doesn't matter if you go unmedicated, you get epiduralized, or you have a C-section. The cost of birth is pain. And that is a fact that you have to face right off the bat. Now, can you get pain management in labor? For sure. But what is really important for people to know is that there were some studies done when I was in school 10 years ago that basically said it didn't matter when you got your epidural. Back, in the 1980s and 1990s, when people were utilizing epidurals for the first time as pain management in labor, they weren't allowed to get epidurals until they were like 5 to 6 centimeters or in active labor. And then if they were complete or they were too far into their labor process, they didn't do it. And then a bunch of studies were
What I've heard
done.
too.
Yeah, that said basically, oh, there's no difference. There's no difference in C-section rates in women if you get your epidural when you're 1 centimeter or you get your epidural when you're complete. And just as you know, as a professional, as someone with a master's degree who understands science and literature, I highly disagree with these studies, because as a clinician, as someone who has watched this and practiced it multiple different ways, women who come into labor and get their epidurals early have higher rates of C-section. And there's a couple different
Mm,
reasons why that is, in my opinion. Number one, you slow movement down. And if you don't have a nurse who's highly committed to moving your body every 30 minutes, your baby's going to get stuck in rotation somewhere. Number two, think about how lax your legs are. You can't walk, you can't move around. Your uterus also responds to the epidural, and those contractions aren't as strong when we add an epidural, especially for women who weren't active to begin with. Like if you're 2 to 3 centimeters and you get an epidural, it's going to shut down your labor. Now we have
mm.
to augment. We have to augment with Pitocin. We have to do all of these things. And the third and biggest reason that I think is very important for people to understand this is epidural. This is science, and the studies do show this. Epidurals have a twofold increase in instrumented birth. And what that means for you is if your doctor doesn't do vacuum or forceps, it's a twofold increase in C section.
You're going right to the operating
Because if
room.
you
Yep.
can't push your baby out, they're not going to help you. And I really hate to say that because I am so blessed to work with a doctor who offers every one of my patients instrumented delivery if they need it. I mean, I would be doing double, if not triple, the amount of C sections if I didn't have someone like Dr. Herbie on my side. In my previous practice, not all of my doctors even offered vacuum. And for me, that is wild that you would tell a woman to get an epidural like without
And without,
any informed consent
yeah,
around it. And not tell her, but by the way, if you can't push your baby out, I can't help you because I don't offer those services. And I
mm,
also piss
that's like
people.
negligence.
Well, it's informed consent is
Yeah,
not happening across the board
yeah.
in all of medicine. And when I hear these blanket statements like, oh, yeah, like I love epidurals. I'm so grateful for them. I love C sections. I'm so grateful for them. When we need these things, I am so blessed
Need
to
them.
have them as tools. But to apply a tool and not tell somebody the risks, the benefits, and the side effects of all of the things, you're the patient is, we're negligent in our teaching and they are negligent in their ability to make a decision because they're not making it based off of valid information. And I'm guessing if they had all of that literature and all of that information, women would be choosing differently. They wouldn't have spent, they'd say, no, I don't want that, or I don't want that right now. Or they would say, I'm not going to see an OB who doesn't do vacuums or forceps because that's your job. And why are you not training
Wow. Oh my gosh, I love this.
it?
Okay, so now we're on the topic of OBs. What's the difference between an OB and a midwife for someone that's like maybe it's their first birth or they're newly pregnant? And why would someone choose one versus the other, or like your practice where you're together with an
Yeah.
OB?
Yeah. So I think what's most important to take into consideration, I was just actually teaching this morning at BUMC. There's a conceptual framework that's laid out that is taken from Sweden and the Netherlands and other countries who the majority of the workforce for obstetrics is midwives. So here in the
Hmm,
United
yeah.
States, 10 years ago, 1% of patients were attended by midwifery birth. Now, we're coming upwards to 8 to 10% of people are attended by midwives and 90% are attended by OBs. In other countries like the Netherlands or Switzerland, where maternal and neonatal morbidity and mortality rates are much lower than in the United States, they use this conceptual framework where midwives do the majority of the work. So they're taking care of 90% of the patients. The
Mm,
10% of patients who become high risk, preeclamptic, have something or some complication in their labor process that would require them to need a higher skill level than what I can do, then they are passed on to OBs. And I don't want to say passed on,
got it.
but then that collaboration happens. So we brought midwives back into the picture to care for women because prior to obstetrics 100 years ago, that's who attended births. And they were lay. They were not trained. They were, your mom, your sister, your auntie, and your neighbor came over And these women had old ancient remedies that were passed on because there wasn't medicine and there
Yeah.
weren't C-sections, and you had to get these babies out or you would lose women. So women were very proactive about figuring out how to birth. So when obstetrics came, we lost midwives. They were kind of pushed out, and obstetrics were pulled in. And then we got into the history of midwifery is long and kind of convoluted, but we
I
are
love
where
it.
we are now. And we were mainly obstetrics about 10 years ago, where 1% were midwives, 99% were cared for by OBs. And OBs have medical training. So they have an undergrad, they go to medical school for 4 years of training in medicine. And then, based off of what type of residency they choose for OB, I want to say they do a full 4 years of training, obstetrics and gynecology. So that's OB training. Midwifery training for certified nurse midwives like I am, you've got 4 years of nursing, which is a bachelor's in the science of nursing, and then 2 to 3 year degree in the master's of nursing with an emphasis on midwifery.
Hmm.
So our training is very different because the medical model is taught some physiology and a lot of pathology, whereas midwifery is taught a lot of physiology and a little bit of pathology. So we're
Hmm.
really training from a standpoint as midwives that birth is a natural part of human evolution, and sometimes it goes wrong, but most times if you keep a woman healthy and safe, she's able to do it without a lot of intervention from us, right? Whereas
I always think back to like cavemen days. Like, how did we get so far
from,
into the medical system?
yeah,
Right? Like, we were born for this.
right. We swung so hard. And in our Western medicine, we've kind of taught women like you can't really do this on your own, even though you're a mammal, and every mammal under the sun births their babies actually without help from other people.
In the wild.
Yeah, in the wild, alone. And I'm not saying that we should be going back to caveman days because women died frequently of infection or if their baby got stuck and they didn't have options to cesarean. What has happened is that we learned all these really amazing interventions and then we started utilizing them in the
Too much.
name that we knew better than the woman's body. And
Mm.
anytime we overuse anything, we run the risk of creating problems. Like, you don't really want to disrupt a laboring mom if she's doing things right. And in the medical system, they're just not really taught to sit and observe. I mean, even the nurses and stuff, like, there is no training on physiologic birth.
Wow.
So, I have learned birth not just from midwifery, but from watching birth for so long. I can listen in a room and tell a woman who's dystosed from a woman who's complete and ready to push by never touching her or seeing her, just by hearing the sounds that she's making. Because
Mm.
if you watch birth long enough, you learn the difference between a woman who is fighting her body and slowly accepting versus a woman who is suffering. And when a woman is suffering, there's something mentally or physically going on that's keeping her from moving on to the next stage of labor. And we just don't do a good job of teaching people that. It's a dying art,
Yeah.
honestly.
Okay. So, someone who is wanting
Mhm.
midwifery,
Yeah.
do they need both? Can they have both? Like, because some people might be like for their first birth, and I know I see this a lot where people are like, oh, I want to do it for my second or maybe my third, or like they wait to do like the home birth, the
Yeah.
midwifery thing. What would you say to someone who's like newly pregnant, maybe is entertained by the idea of having a midwife? Like for me, I'm like 100% for sure. Like I'm out there. I'm in left field. Okay. So I'm ready for that. But there might be someone that might be conflicted. And how do they make that decision?
Yeah.
Like what does the midwifery change, like the emotional experience of pregnancy and birth, and what's going to draw someone to that?
Yeah. So there's definitely multiple different models of care for midwifery. You've got home birth midwives, which are CP. I mean, CNMs do home birth as well too. I do some home birth in my practice. A majority of my birth is in hospital, but um, I think the first thing that I can say is I am a relationship builder, and I find most midwives are. When you come to see me, I'm not just looking at your health history. I want to know everything about you. I want to know about your childhood trauma. I want to know about where you work. I want to know about the problems you have inside of your marriage. I want to know about the relationship that you have with your mom and dad. I want to
Mhm.
know everything I possibly can because it's what allows me to tailor your care to work for you. We have been cookie cutting medicine to make it safe, standardized for way too long. So now it's like this stamp for everyone. And we are individuals that need very individualized care. So, what I find to be most intriguing for midwifery is that all of the midwives I know, they're interested in building relationships with their patients and getting to know them, getting to walk alongside them throughout their journey. I mean, I've had the luxury of taking 16-year-old girls who came to me 10 years ago for a GYN problem, they had heavy bleeding, and then they came and saw me yearly. And then I helped them with birth control through college. I've had some of them go to college to be midwives because they loved the relationships that we built
Mhm.
inside of our exam rooms. I have seen them through pregnancy. One of my patients saw me when she was 16 and we just had our fourth baby together.
Wow.
Um, I'm we're
So
in
cool.
it for the long haul. Like I am helping you mentally, physically, keeping you as healthy as possible as a human being, giving you all of the tools and resources that I've learned along the way, not only as a provider, but as a mother and as a pregnant and birthing woman myself. And I'm very invested in my patient and knowing her and her outcomes. And I think that's what sets midwifery aside. And I'm not saying that your OB doesn't want to, and I'm not saying that there's OBs who don't, but we have a crisis in America and we don't have enough OBs. So they're spending 5 minutes with patients, 10 minutes max. There's no preventative healthcare going on. We keep running in circles around how do we change maternal outcomes. You can bring in midwives all day long, but if you're going to put them in obstetrical offices where they're asked to practice obstetrics alongside OBs and they get 5 minute appointments and they're little mini OBs, you're not going to change the outcomes. These midwives in the Netherlands and in Sweden, they don't practice obstetrics, they practice midwifery. That's why they're able to reduce the rate of C section to 10%. It's
Wow.
why continuity of care model has time and time again been proven to be one of the ways to keep a woman safest is this woman knows her midwife, or at least like for my patients, I'm in a call team of going to be 7 midwives, and we are like married sisters. We may practice a little different and have different recipes for the medicine that we practice, but we are 100% in line for autonomous, empowered birth for women. So I
Mhm.
take my patients and I see them through their whole pregnancy, and I prepare them with every ounce of what I have in me to go into their birth space, and they are prepared. If I'm not there for some reason to hold that space for them, you bet for sure my partner is. And we hold on to those women so tightly. We build relationships with them so quickly because we found that if we do the traditional model, like these other midwifery practices and obstetrical practices where they round robin, you go to meet every one of the 12 providers and you only see someone once, who's building the relationship? Who's
Mhm.
figuring out or deducing some of these problems? Hey, this woman has birth trauma, or she has trauma from her previous birth. She's history of rape. She's divorced and she doesn't have any support. She's a single mom. Like, you really have to build a relationship with a patient to really treat them as a whole person. And that's what makes midwifery different. Now, inside of my practice, you get an OB and a midwife when you get me because I tell patients all the time, and I keep my whole team up on the wall, and I keep Dr. Herbie on the wall, and I say, this is my OB. I like to think of him as Batman. He's always around. He's always here to save the day. He's lurking in the background. But if you never have to meet Herbie, I did my job right. Our goal
Mm,
is for you to never have to see my OB because he's so busy taking care of the other patients who do actually need his services, his surgical skills, and his expertise, that I'm over here being busy taking care of the people who don't. In the event that my patient ever, at any point in her pregnancy, needs higher services, I don't punt her. I don't say, get out of my practice. You're too high risk for me. I keep her. She's my patient, and she starts to see Dr. Herbie as well. Sometimes my patients are so high risk that they also need maternal fetal medicine. So the people above Herbie, and they see maternal fetal medicine, and I work with maternal fetal medicine and take in all the recommendations, but I'm still the person doing their care. I'm still the person at their delivery. I'm still the person first assisting Dr. Herbie on their cesarean, and I'm assuming their care as soon as surgery is over. Like my patients, I've never had a patient where I've been like, you're out, you're just too high risk, especially in her pregnancy. If we're established, that would be so detrimental for her to lose her primary midwife that she's known and trusted. So
yeah.
yeah, you get both when you get me, but you don't necessarily meet Herbie unless I foresee a reason. There are times, like my twins, they always meet Herbie at least once because he's going to be
Mm,
there. He's coming in on that delivery with me because multiple times one of these babies are butt down and we're going to do a breech delivery, or I'm going to need some assistance from him. So yeah, you'll go meet Dr. Herbie and then they'll say like, Tracy's my midwife, and Dr. Herbie's my OB. But the primary person taking care, like 99% of that care, is through your midwife.
oh my gosh. That is so informative. That's obviously a lot of news to me. Like, I didn't know all of the details of that. And that makes me hopeful for a lot of women to also listening to this. Because, like, you just explained it beautifully, the difference between the two and why maybe somebody would want one versus the other, or a practice that has both.
Yeah,
And like you're saying, like midwifery, your main job is the person in front of you and getting the baby out. With OB and OBGYN, they have so many other things to be worrying about, so many more patients to be seeing. And you never know, too, if they're on rotation or whatever, if they're going to be actually
right,
delivering your baby. There's a whole team involved. And I love that you explained that. I think that's really helpful for someone to maybe understand, so especially for like their first birth, because they don't know. People just really don't know. And they're just like, oh, I guess I just have to go to OB.
right.
Yeah.
And I think what happens here in the United States, which sucks because the midwifery model was made to, that conceptual framework was made to protect OBs from burnout, to create more
Mm,
workforce for women, women caring for women inside of their communities.
that's
We've
very
created this system where midwives are seeing high risk patients and low risk patients, and doctors are seeing low risk patients and high risk patients. And they're almost like, I don't want to say equals because they still can do more than us as far as like surgery and stuff is concerned. But it wasn't designed to be that way. It was designed to reduce the burden so that our OBs could become specialists to the high risk. An
yeah.
OB to me should be the most, like Herbie is a great example. He has every skill I don't have. When I run out of options to safely help my moms, I tap him in because he has that. And like he says to me, I'm a man. I don't want to be sitting in here with this mom laboring naked on the bed running around. That's an invasion of her birth space. She needs you, a woman she knows and she trusts. But because I've spoken so highly of Herbie throughout her entire pregnancy, and she knows that I know him and she trusts me, if I have
Yep.
to invite him into that space, he's
It's
welcome
okay.
there.
Yep.
And he's there for a short amount of time. And I
Mm,
really feel bad, honestly, for OBs because I think they go into it altruistically for the same reasons I did, but they get stuck by insurance and hospital systems in this system where they have to see all these patients in order to pay their salary, pay their MA, pay their overhead. We're all kind of stuck in this hamster wheel of a system with insurance and stuff. So I don't criticize OBs in any way. I love them, but it would be exhausting to care for 40 people. Like I only have so many emotional exchanges to give in a day. And when I'm seeing more than 20 people, when I leave my office, I have nothing left to give anybody else because I just gave you 30%. It's a back
Right.
and forth relationship. And you
Mm-hmm.
can only build so many relationships during the day. So I feel really bad because the midwifery model of care is not being managed the way it's supposed to inside the United States. I think these OBs think I'm going to get these midwives to come in. It's going to be a little bit cheaper. They're going to do some of our work for us, but they don't really understand that we're supposed to be shifting the pie, right? Like, stop
Mm-hmm.
taking normal healthy people and let the midwives disseminate education and prepare these people, because what happens if you really want to boil down is these sweet little healthy young patients come into practice and they have an OB and they have no complications during their pregnancy, and they get to 39 weeks and suddenly this this OB or this midwife who has a lot of patients is suddenly like, shoot, I got 40 people on my roster who are all 40 weeks, and I need to kind of manage some of this because I don't want anyone to get too post date. So we start to practice fear based medicine. And it's like, hey, why don't we just get you in for an induction? I want to deliver you. And we start manipulating birth. And birth was not meant to be manipulated. Quite contrary. I tell my patients all the time, the biggest way that I can protect you inside of your birth space is to keep you healthy so long, so far into your pregnancy, that your pregnancy will end before you get sick, because there comes a time in pregnancy where your body's like, get out, this is too much for me to continue
Mm-hmm.
brewing this baby, and it's time for this
Yeah.
baby to take over its own autonomy. um,
Wow.
and I find too often that people will say to me, I didn't know what I didn't know. So they you want to have a baby at 39 weeks? Yeah, sure. I'm ready. I'm done. Everyone's done with their pregnancy. They sign up for this induction. Their cervix isn't ripe. Their baby isn't low. Their body isn't ready. They end up in a 3-day induction. The baby gets stressed from Pitocin, and mom gets tired from being in labor for that long. The next thing you know, baby's no longer happy. The water's been broken. We've got an infection going on. We're going to the OR. Now we're going to the OR, and I've had an epidural in for 35 hours and it's not working the way it would have worked if it had only been in for 12 hours like it was supposed to. Now I got a mom who's getting an operation awake on a table and she can feel what we're doing. And our option is put her to sleep and she misses the birth of her baby, or traumatize her and continue with her surgery. Sure,
Mm-hmm.
breastfeeding gets down regulated because there's separation between mom and baby, and lactogenesis 2 doesn't get to happen. We down regulate the pituitary because our iron stores are lower. And now this baby, mom's breastfeeding journey is also being
Impact.
wrecked at the beginning of its journey, and moms are leaving 35% of the time. 1 in 3 women walk into the hospital to have a baby, and one out of those 3 women walk out with major abdominal surgery and a baby to take care of, with zero resources or support around her. And we're confused why people have trauma while they're leaving their birth spaces traumatized. So
Mm.
it's a problem.
You just laid it out in the most. I hope that this podcast, for the sake of like your profession and our profession of women's healthcare, gets widespread, because this is the conversation that has been missing. And we can talk about it until we're blue in the face, but until people actually realize it,
Yeah.
it's never going to change.
Yeah.
But we're making momentum. We are making way, and we're going to stay positive about
We're
that.
staying positive.
Okay, so I have some rapid fire questions because one, I'm a curious human being and I want to know, but two, because maybe listeners also want to know.
Okay.
Okay, so first question would be, you said vaginal birth, baby's breech. How are we, like, say a woman is 40, 41 weeks and they're wanting vaginal birth. Do we deliver breech? Like, how can we do this?
We deliver breech. We do.
Okay, so women don't need to automatically have a C-section, schedule a C-section, like,
Yeah.
ease the listener's mind here.
Yeah. So the ACOG recommends that breech babies be delivered via cesarean, primary cesarean scheduled. But that's the ACOG's recommendation. It's generally safer for the baby. It's not safer for the mom. So what we tell our patients is we can tell you the recommendations based off of what ACOG recommends, but a mom has every ability to choose for herself. Breech birth is technically a variation of normal. And women have been delivering breech babies for as long as the human race has been around.
Mm,
And although there are more complications associated with it, if you are counseled properly, which Dr. Hervey counsels all of our patients on breech birth, and you show up to the hospital and say you don't want to do a C section, you have every right to do so. Now, what you need to understand is if you do that and you have an OB who is not skilled at breech, that puts you at even more risk for an adverse outcome for your baby. So it's very, very important that you find a provider. I only know of Herbie who's doing breech birth here in the Valley, and he does quite a bit of breech birth, and he's trained all of us midwives in breech birth with him. So
amazing.
yeah, you do
Awesome.
have options.
Okay, especially for a woman who's maybe like doing a home birth, like, and maybe they're midwives. Like, what does that look like? The baby's breech at home? Do they have to go into the hospital?
Yeah. So I am probably a little bit conservative on this because I still have that conceptual framework that normal physiologic birth can be done outside of the hospital and high
Mhm.
risk birth should be done in the hospital. If
Right.
we know that babies and moms have a higher risk of an adverse outcome, to me, that is the people who should deliver in the hospital. So,
Mhm.
yes, there are definitely skilled, trained midwives. I would say midwives are more skilled and more trained than many OBs because they're just not training that anymore at delivering breech birth. But I still personally believe that breech birth belongs in the hospital where you have skilled providers and you have a team of people who are there to help the baby in the event that the baby needs help when it's born.
Okay,
So
I love
yes, women this is where we're at in healthcare because the OBs are no longer training it. They're no longer training vacuums, forceps, and breeches. Women are delivering outside of the hospital with
yeah.
community-based midwives, which I commend. I commend the bravery of these midwives who are holding space for these women to make autonomous choices for their body because they're showing up in hospitals and they're told, you can't do this. You have no choice. We won't help you. We won't do anything if you choose to continue on with this labor.
Wow.
And as a human right activist, it blows my mind because bodily autonomy is number one to me. You get
Yes,
to choose what you do with your body, not somebody else.
absolutely. Oh my gosh, this is such a good conversation. Okay, second question, because I'm curious, human being. How long can people stay pregnant? Like, what's the longest you've seen? Like 43 weeks, like 42 weeks? When are we hijacking out?
I wish I had Dr. Howard here to answer this because he's the oldest OB I know at this juncture. And I was saying to him once because he lets me just do my thing. He used to supervise me, and although we have kind of different philosophies of care, we have a very respectful relationship with each other's skill sets. And he told me like when he was in training, people would go to like 46 weeks, and I was like, oh my gosh, like what did you do? He was like, Tracy, we didn't have like we didn't know how to get people unpregnant. You didn't have a
Yeah,
choice. Like that's
yeah.
he's like, it was horrible. They had terrible outcomes. I highly don't recommend it. Um,
That's a big baby.
it's a bit, well, I think there comes probably a point at which the placenta, you start reverse aging, right? You're not growing bigger anymore. The placenta can only grow it so big. And I imagine at some capacity from environmental exposures, we're going to get some calcifications. It's just not going to create a great environment for that back and forth flow. But um,
Yeah.
I have a bias that is really important for you to understand because in the state of Arizona and most states in the hospital, if your patient goes over 42 weeks, she's no longer a candidate for midwifery care. So I have I obviously read the literature. I do a lot of investigation and keep up to date on evidence based birth. Some of the latest studies show that in the 41st week of pregnancy, you start to see some statistical significance of poor outcomes for moms and babies the further into the gestation they get. So, for me, because 42 is that hard number, I usually tell my patients, like, I'll do nothing up to 42 weeks. But at 42 weeks, I'm very blessed that Dr. Hervey allows me to still care for those patients. It's not like I'm handing them off, he's just more involved in the care.
Right.
But my personal experience is that if your baby, you have outliers for sure. I have patients who come to me and they're like, my mom was pregnant for 42 weeks. My sister was pregnant for 42 weeks. Are you going to badger me? Are you going to give me a hard time? And I tell people, like, no, like, I'm not going to badger you or give you a hard time. I'm going to ask you
Yeah.
to do antenatal testing. I'm going to badger you by calling you every day and saying, is your baby moving? How do you feel?
Are you ready?
Blood pressure. How's this? So
Yeah.
get much more involved. I see my patients in the 41st week of pregnancy. I try to see them every 2, maximum 3 days, checking in on them. I like to get my hands on baby. I like to have those babies kicking back. We do non-stress tests and BPPs, but
Okay.
I like that. But I'm a high touch person, so I like to get in there and get my baby to react to me and kick me back. I like to feel the buoyancy of the belly and make sure I still have amniotic fluid in there. So
Okay.
I am not in the mindset that we are the people who get to choose how long a person stays pregnant. But in my experience, which is very limited as to taking care of patients who are 42 weeks or greater, I find for most of my patients, if their babies aren't here by 42-ish weeks, there's probably a reason why they're not coming down into the pelvis. And sometimes that has to do with, is mom ready? Is she ready to give birth
Mm,
to this baby?
that's good. That's good.
Yeah.
Wow. I love that. Well, thanks for sharing your amazing insight today. I'm going to have one last question. It's a question I'm going to ask everyone on this podcast is it's called the female blueprint. So I'm curious, what's one piece of advice or like a blueprint or a rule that you were told to follow as a little girl or a woman, growing up and now in your career that you've since thrown out? And then what did you replace it with?
That's a good question.
Very good.
um, I was told, maybe not these words, but society for a 45-year-old woman who was born in the early 1980s, I was told to not take up too much space. And I didn't. So much so that I struggled with anorexia for 2 decades, trying to stay as small and not to step on. I had a big personality at a young age, and my mom and dad used to always tell me that mouth of yours is going to get you in trouble. And they always tried to press it down. And the more they tried to push me down, the more, and I don't mean that in a bad way, but they were a part of society and they're like, my God, we got this mouthy girl we're raising. Um, and I would say I threw it out the window. I didn't truly like let it go, like release it until I was 35. And now I'm like, take up all the fucking space you need, because
Absolutely.
I want to see women strong. I want to see them healthy. I want to see them lifting weights. I don't want to see them trying to take up the space you need to take up, and own the things that you're passionate about. Become an expert in something you love and care about and share it with the world, because that's what we need. We need more women who trust in their self and their innate ability to do things than we do telling women to take up less space.
Absolutely. Retweet that one. That's so good. Well, thank you so much. This podcast is like so long and thank you for your time. But these are conversations that need to be had and women need to hear. And I'm so excited to do it with you because I look up to you.
Thank you.
And yeah, I adore you and I adore everything that you do. And
You're so
I
sweet.
mean,
And I just want to tell you, this. I feel the same way about you. I remember the first time I met you and I thought, oh, she's going to do some great stuff. So I love it. I love what you're doing. Keep crushing it.
yes,
Thank you so much for having me. And I feel the same way you do. I hope
yeah,
this podcast gets out there to the general population, because we need
yes,
more women, pregnant women,
we do.
understanding this system.
We do. Well, where can people find you if they want to, one, work with you, be your midwife, and two, just connect with you and learn from you?
Yeah, so I do a lot of stuff on Instagram. That's Modern Day Midwife. My website is www.moderndaymidwife.com. And I work out a premier OBGYN in Central Phoenix with a team of, in my opinion, the best of the best midwives that there is, and hands down, the best OBGYN. And you can come and see me there. And then I do a lot of wellness, cash pay, hormones, and nutrition based stuff out of the Hive on the west side. So if you inquire to me at www.moderndaymidwife.com, I can get you all the resources you need to become a patient.
Amazing. And I love that you're at Premier OBGYN now and you were on the west side because you're what, like 35 minutes away, and now you're literally 4 minutes away from my house. I'm like, okay, we're good. We're good.
We're good. We'll have you taken care of, I promise.
Uh, all right. Amazing. Thank you so much.
Absolutely. So good to see you.
You too. If you guys like this episode, don't forget to follow the Female Blueprint podcast and leave a 5-star review. It really helps me reach more women who need to hear these messages. And if someone popped into your mind while you were listening today, maybe a friend, a sister, a client, share this episode with them. You never know how much it might help them feel less alone, or even be the nudge that they need to finally start rewriting the blueprint for their own life. Thank you for being here, thank you for listening, and thank you for being a part of this community. I'll see you in the next episode.